Thank you for the introduction, and thank you, Professor Mebaza, for giving me the opportunity to present those results. So my name is Adrien Picod. I'm an anesthesiologist and intensivist in Paris, and currently a PhD student in Alexandre Mebaza's lab. So my talk today is about a study assessing the prognostic impact of IL-6 or C-reactive protein in critically ill patients. So, as you may know, interleukin-6 is a mediator of the inflammatory response to both septic and non-septic aggression. It is the main inductor of C-reactive protein synthesis and release, and it has been implicated in several mechanisms leading to shock, such as vascular leakage, myocardial depression, or vasoplegia. From the literature in critically ill patients, we know that IL-6 is associated with the worst prognosis during sepsis, but in other contexts, data is very limited. Conversely, CRP does not associate with survival, but most studies are small sizes and limited to septic patients. So our objective was to assess the prognostic impact of IL-6 or CRP concentrations on survival and the need for organ support in a large cohort of ICU patients. For that, we use data and blood samples from the frog ICU cohort, which the design of which was already presented by Benjamin and Louis. And we use the first blood sample on inclusion in the study to measure CRP and IL-6. And our main endpoint was 90-day survival. So here are the characteristics of the patients and the 2,076 patients we included in our study. And you can see that these are rather ill patients with a median SAPS-2 of 49, a median SOFA of 8. There is 1/3 women, and a quarter of patients were admitted for septic reasons. The overall mortality was 30%. So the median IL-6 was 100.9 picogram per milliliter, and IL-6 that is higher than median was associated with male sex and comorbidities evaluated by the Charlson Comorbidity Index, the SOFA score on each one of its components, the need for vasopressor inotropes at baseline, ICU length of stay, and day-night mortality. And on the figure, which was supposed to be in color, but believe me, the IL-6 concentration was higher in patients with hemorrhagic shock. For CRP, the median was 143.7 milligram per liter, and in univariate analysis, high CRP was associated with age, male sex, the need for vasopressor inotropes are at baseline, and ICU length of stay. And there was only a trend to higher day-night mortality. Concerning survival, you can see on these three figures in the upper panel the Kaplan-Meier curve, and in the lower panel the hazard ratio adjusted on SEPS2. For IL-6, when stratifying on the median in the study, we showed that the median pretty well stratified the survival of patients, and this effect was conserved across patients' subgroups, and in particular in septic and non-septic patients. Whereas for CRP, the stratification on the median was significant, but the size of the effect was very low, very small, and the association was lost when considering only septic patients. We next divided our population into four subgroups according to the median level of both biomarker, with two concordant groups with both low levels of biomarker or high level of biomarker respectively, and 2 discordant groups. And what we can see on the third figure is that there is a significant difference in survival between patients with low and high IL-6, but for one category of IL-6, further stratifying on CRP does not refine the analysis. We then looked at the association between the level of each biomarker as a continuous variable and the probability of day 90 death. And we found that there is a log linear association between IL-6 and death, translating into a odds ratio of 2.04 per incremental log, decimal log of IL-6, that is for each 10-fold increase. And conversely, the relationship with, between CRP and mortality was small but significant, and the incremental risk was minimal. Last, we looked at the need for organ support, and we found that IL-6 was consistently associated with the need for renal replacement therapy and the need for vasopressor inotropes, both when considering patients, all patients, and when considering only patients that were independent from the given support at inclusion in the study, that meaning at the time of the blood sampling. And for CRP, there is no clear association, at least not consistent association between conserve in all patients or in patients independent from the support at baseline. So to summarize, overall IL-6 seems to outperform CRP for patient prognostications. The main strength of our study is that we included a large ICU population, including both septic and non-septic patients. And some limitation could be that the time to blood sampling in the frog ICU was, there was some time between the admission and the inclusion, that is the time of blood sampling, that could have influenced some of the results according to the different kinetics of the 2 biomarkers. And also we focused on one limited aspect of the host immune response to aggression. And we could have looked at other biomarker, other inflammatory or anti-inflammatory biomarker. So to conclude, when assessing the prognosis of critically ill patients, you should prefer the IL-6 over CRP. Thank you for your attention, and thank you to all collaborators on this study.
Thank you, Adrien, for this excellent presentation. Now it's time for questions from the floor. There.
Thank you very much for presenting this very interesting data. I was just wondering if maybe you have an idea or can comment on, if I saw correctly, IL-6 as a prognostic factor for renal replacement therapy was not significant in septic patients. And I would have expected that, especially maybe in septic patients where there's a lot of inflammation, there would be a really relevant association between IL-6 and severity of disease or renal replacement therapy. Do you have any explanation why in those patients it's not?
Thank you for this question. You're right. It was a surprising finding that overall the prognostic performance of IL-6 seems to be lower in septic patients. I have no definite explanation, but I have hypothesis, and I think the main hypothesis is that results in the septic population could have been influenced by the timing of the blood sampling. We know from previous paper that in sepsis, IL-6 is higher right on admission, and then it declines rapidly. So as there is a substantial time in our study between the admission and the inclusion in frog ICU, that is at least 24 hours by design, then the lower in the septic population, the level of IL-6 in the septic population could have declined rapidly, and then the association might be lost. That's one hypothesis.
Your time is